Marcelo's here to talk about Medicare and some Medicare changes in light of the Affordable Care Act, which obviously can be a controversial issue, but obviously, Marcelo and Sourcewise and BAAKP are very much focused on the very objective, factual presentation of the changes that may be coming. So, one more thing, Marcelo is a graduate from St. Mary's College, Cal Poly, and UC Berkeley. Marcelo, thank you very much for joining us. Give me 1 minute to not talk over here.
Hi, thank you everybody for having me today. I've had the pleasure of working with Ben and Patrick about the changes in the health insurance landscape, especially as it relates to Medicare. And I've asked many questions. I've had to do a lot of research. We're still learning about the effects of the Affordable Care Act, but I'm going to share with you what I've learned. First, a little bit about Sourcewise. As Ben mentioned, we are previously Council on Aging Silicon Valley. So our goal is really to help seniors age well at home and provide expertise, education, and quality support services to Santa Clara County residents, their families, and caregivers. We offer direct services. These are some of them. So when you call us, you'll be connected to our Information and Awareness Department. And this is a great resource if you want to learn about programs in the county or even in-house. They're the first people to talk to. We have a care management program. It's for people who are on Medi-Cal. Our social workers go out and talk to them, develop a care plan. We also offer senior employment services for people over 55 to help them get back into the workplace. And we have a Meals on Wheels program. So we provide frozen meals for people who are homebound. If they don't have a microwave, we'll provide a microwave as well. I'm in the Health Insurance Counseling and Advocacy program. And what this is, it's part of a national network of state health insurance and assistance programs. HICAPs are the local source of help for people with Medicare. We work through a number of counselors, volunteer counselors who are state certified. They are stationed at various senior centers throughout the county, as well as doing counseling at our office off the Alameda, and 880 is where we're located. This is our phone number. You can always call us for an appointment or go to the senior center. We even have a counselor out of the Stanford Health Library. His name is Don Rush. He's not only a HICAP counselor, but he's very versed in long-term care insurance as well. So today, sorry, it doesn't seem to be rendering that properly, but the Patient Protection and Affordable Care Act, we'll refer to it as the ACA. I'll be talking about that, as well as how it relates to Medicare, and in particular, some items when it comes to people with Medicare and End Stage Renal Disease. As the doctor pointed out, the kidneys is a very unique organ, and when it comes to Medicare and End Stage Renal Disease, there's so many, it's a very unique program in the Medicare program, and we'll get to that. So there is a changing landscape. I would like to talk about the different patient protections, the new health insurance marketplace, and how Medicare fits into that or doesn't fit into that. And then we'll look at some of the changes to Medicare itself that affect coverage for people. Being in the football season, I'm going to use a little analogy here. After the loss, I was listening to the radio. One of the former quarterbacks was talking about how he handles situations after he's called to play. So he has a set of receivers that he looks at, and he knows once the ball is snapped who he wants to look for to throw his ball to. If that doesn't work, he'll do a check down. Basically, he'll go through his receivers and see who's open, who's available, until he hits them. So we're going to go through an insurance check down before the ACA happened. Basically, I want to show you the landscape of what people's options were. Now, in our country, health insurance is tied to employment coverage. That's just how it is. So most people are covered by employer coverage. Okay, so I'm going to look at it from the standpoint of if you're working or if you're not working. I apologize for this, but so when you're working, you have what's called employer group health coverage, and it's great. You get this coverage, and not only that, somebody helps pay for it for you. And I think ideally, there are a lot of people who get employer group health coverage all the way through age 65, and there's not much of an issue. Okay? Or maybe there was, but now let's look at if a person has lost work, what happens? The option for them is what's called COBRA coverage. And there's basically a law that says you get to keep your insurance for 36 months. That's the maximum amount of time you can keep it. But you're going to have to pay the full premium. So instead of paying a small portion, it probably doubles, maybe more. So it can be quite costly, especially with no more income. After COBRA coverage ends, then there's something called a conversion plan. So a company can offer you insurance that converts from that group health insurance that you have from your employer into an individual plan. And again, you pay for it. It's more expensive than what you were used to paying through your employer. If a company doesn't offer you a conversion plan, then the next thing is you fall under what's called a HIPAA regulation. This basically says that no one can deny you insurance for a period of time. Insurance companies have to offer you this insurance. And the issue with this is still cost. These were quite expensive. Okay, so once you're out of that situation, maybe you just have no work, and you're forced to look on the private market for an individual plan. Okay. Has anyone ever shopped for insurance before? And do you know how complicated it can be? Maybe you don't even know what you're actually getting covered. It's very difficult, and it can be quite pricey, especially for someone who has a pre-existing condition. They may not even take you because of a pre-existing condition. If they did, then again, maybe the price would be exorbitant. Or the coverage may be quite spotty until you need it, and you find out, wow, I really didn't get what I was thinking. The other option is the Major Risk Medical Insurance Pool, Mr. MIP. So if you had been denied insurance, California created this pool where you could go and buy insurance without they'd have to take you. Maybe there was a waiting list offered by some private companies. In our area, I think it's Anthem and Kaiser that are part of the Mr. MIP program. Again, costly for some people, relatively, especially if you aren't working. Now, suppose your income is limited or you have lower resources. Well, the option then is you look to the state. Have you heard of the Medicaid program? It's basically, in our state, it's Medi-Cal for people with lower income and resources. But if you're like me, I used to think Medi-Cal, anybody could get Medi-Cal. That's not true. It's for certain populations. So Medi-Cal's for families, children with their parents. If you are aged, above 65, as they say. If you have a disability. But people aged 19 to 64 who don't fall in that category could not get Medi-Cal. They were excluded. So again, the main issues. Pre-existing conditions. They could ask, insurance companies could ask you, and they could deny you. And you were exposed to all the costs. Relatively expensive for people who were not working. And the coverage that you could get there. You could go to the hospital or you could come up with a condition and maybe they would not cover that particular condition or maybe drop you from a plan eventually. So, and furthermore, a large population was excluded from Medi-Cal. So, in our country, before the ACA, millions were without adequate health coverage, exposed to financial ruin, loss of health, and in cases, a loss of life. So, what has happened now with the Affordable Care Act? Plans are no longer allowed to refuse or delay coverage or charge higher premiums due to pre-existing conditions. This is quite a large one for a lot of people. And let me step back. The reason I'm talking about this is because there's an individual mandate in it. Everybody has to have qualified health insurance. When I say qualified, and let me get this out of the way now. If you have Medicare Part A, they consider that as having qualified health insurance. So you don't have to do anything in terms of shopping on the exchange. Children can stay on parents' policies until age 26. There are no more annual or lifetime limits on essential health benefits. And all plans moving forward must cover 10 essential health benefit categories. And in our state, what is a essential health benefit? It's written into the law, but it references a plan, a Kaiser plan, that was in effect in 2012. And if you look at the list of benefits that they include, you'll get a better idea of the details of what this means. Also, out-of-pocket maximums are part of these plans. So it's one thing to pay a premium. We all know what premiums are, monthly premiums, but it's the out-of-pocket costs, the deductibles, the co-payments when you use services, the co-insurance that starts to add up that we're all trying to figure out how to manage. So out-of-pocket maximums basically say there's a limit on how much you will spend per year on these out-of-pocket costs. So now that we have this mandate, and we talked about how confusing it can be, included in the Affordable Care Act is the creation of these health insurance exchanges, these marketplaces. So maybe you've heard about the trouble with healthcare.gov. So states were at liberty to develop their own health insurance exchanges, or if they said no, we're not going to do that, then the federal government was going to manage their exchange for them. So California jumped on board, and California started what's called, named our exchange Covered California. Jumping ahead of myself here, but one last bullet on exchange. That population from Medi-Cal, 19 to 64, is now included in Medi-Cal. These people can now qualify for Medi-Cal benefits. Okay. So back to the exchanges. Covered California is California's exchange, and we're having more success, I'd say, than the healthcare.gov website. Now, these exchanges are the only place one can go to receive premium tax credits and cost-sharing subsidies. So, in other words, depending on your income, you might get help with a premium or with out-of-pocket costs. But the only way you can avail yourself of those is by purchasing a plan through the exchange. And what they look at is your modified adjusted gross income. These exchange plans, they do not ask about your resources, just about your household modified adjusted gross income. And if you go through the exchange, maybe you're wondering, well, what if I qualify for Medi-Cal? Well, the application process does screen you for Medi-Cal as well. If they find that you do qualify, then they would send you to social services agency. Now, expanded Medi-Cal. That's what I'm calling the inclusion of adults into the Medi-Cal program. There are other ways to qualify for Medi-Cal, and these programs still exist with their own set of criteria. The biggest difference being in the other programs, they still look at your resources. So, as an example, this is a really good chart. I took it from the California Association of Health Plans, basically showing your income level and where you might fall in terms of receiving help for a premium, receiving help for both a premium and cost sharing, or eligibility for Medi-Cal. Again, it's based on household size and income. So these are some of the latest numbers of enrollees in Covered California. So this is mainly for people who do not have health insurance. And the estimate is about 7 million people in California don't have health insurance. So as of the end of December, Covered California is looking at an enrollment of almost 500,000 people. So, you know, we were looking at that check down list of people who didn't fit into any of those categories. Maybe some of you have been through that, but there's some people who just don't have insurance. So over 500,000, we'll probably enroll more than that. Medi-Cal, 1.2 million people since the start of the ACA have been enrolled in Medi-Cal. So we're looking at 1.7 million people who maybe didn't have insurance. Where do you go if you need health care coverage? You don't have a primary care doctor. So the idea behind this is helping people maybe avoid the emergency room for your first source of coverage. Getting the help you need before things really deteriorate. Now, this is not a perfect system, and I'm not here saying this is, you know, everything's going to be hunky-dory, because not everybody's going to benefit from these cost-sharing subsidies. There's probably about 17% who don't fall into one of these categories, and insurance will probably go up. Some people are going to be happy, some really aren't. Okay. So let's look at today's insurance landscape. Again, we still have employer group health coverage. We have people who've retired and maybe their companies offer them retiree health plans. COBRA still exists, conversion plans exist, the private market, individual plans, those still exist. Okay, so the new player on the block is Covered California. Covered California insurance plans are now an option for people. Mr. MIP still exists and is in effect. Medi-Cal is new, and then we still have the old Medi-Cal for people who are aging disabled and who have maybe higher incomes but lower resources can still access Medi-Cal. I think let's talk about one big question that might be on everyone, people who have kidney problems. Will a Covered California plan cover dialysis and transplants, and to what extent? So the answer is yes, but it depends on the plan. So you really have to look at what the plan covers. The plans on Covered California are in metal tiers. I don't know if you've heard about this, but platinum, gold, silver, bronze plans. And a platinum plan is the most expensive plan, but it covers actuarially 90% of the cost of your health care. The gold plan actuarially covers 80% of your projected health care costs and so forth. Now, things change. And we haven't talked about the big insurance here, Medicare. But once you become eligible for Medicare, Covered California doors essentially close for you. Okay? Now, what I'd like to talk about now is Medicare eligibility. And Medicare, let's say, as your only, suppose Medicare were your only insurance and you had none of the other ones that we've talked about. The biggest issue, well, one of the main issues is how do you deal again with those out-of-pocket costs? Okay? Because suppose you have End Stage Renal Disease and you have Medicare. Medicare is like a gold plan. It covers 80%, and the rest of the out-of-pocket costs are your responsibility, 20%. But these can add up quickly, right? So how do you deal with those things? Well, fortunately, all those other plans don't go away, and there are rules. So Medicare does coordinate with some of these other plans still. So these are, and what I mean is Medicare will pay for a service first, and if you have one of these other plans will pick up the rest, the out-of-pocket costs, maybe some of the deductibles that are inherent in Medicare. But we're still learning about these health exchange plans plans, and there are no rules about Medicare coordinating with them. So people who have Medicare and think, okay, I'm going to pick up an exchange plan in the hope that it'll pick up my out-of-pocket costs. That's just not the case. Maybe private individual plans, there are no rules about it, but you have to check with each plan to see how it might coordinate with Medicare. Okay, Medicare eligibility is important because one could move through the different types of Medicare eligibility. The first one let's talk about is Medicare due to end stage renal disease. So eligibility begins the 4th month of dialysis. It can begin on the 1st month if dialysis is performed at home, or the month of kidney transplant. And that's when Medicare can start. You can also qualify for Medicare due to disability, and it starts on the 25th month of receiving SSDI check, Social Security Disability Insurance. And then for most people, Medicare begins on the first day of the 65th birthday. Now the reason I bring these up is because maybe you qualify for Medicare because of end-stage renal disease, but when you hit 65, things can change. There are penalties if you don't sign up for Medicare when you could have. Those penalties go away when you turn 65, so you transition into Medicare due to age instead of ESRD. You can also transition from Medicare due to ESRD into Medicare due to disability, in which case things may change as well for you. And just a little background on Medicare. Anyone entering the program has 2 choices on how to receive their Medicare benefits. The first choice is, well, everyone enrolls in what's called original Medicare. And unlike, who here has employer group health coverage through your employer? Okay. When you signed up, did you think that you were getting, you'd have to sign up for different parts and pieces, or did it all come together? It covered you in the hospital, when you saw the doctor, it covered your drugs. You don't think about the different pieces. Medicare started in 1965, and the pieces of Medicare, there are different pieces of coverage. So Medicare Part A covers you as an inpatient in the hospital. This is not something you have to think about when you're with an employer. Medicare Part B covers you when you're an outpatient, when you're seeing the doctor, it covers durable medical equipment and so forth. And then there's also Medicare Part D, which was introduced in 2006 for drug coverage. But if you have Medicare A and B alone, you can see any doctor in the Medicare system who's enrolled in Medicare throughout the country. Okay? You aren't limited by where you live. So again, with this original Medicare, you can have other insurance that we talked about to pick up the out-of-pocket costs. You can even have a separate Part D drug plan. The other choice you have to receive your Medicare benefits is through what's called a Medicare Advantage plan or an HMO. Who here has a health maintenance organization? Okay. Basically that is you're assigning your Medicare. If you sign up for a Medicare Advantage plan, you're assigning your A and B benefits to a private health plan, an HMO, like Kaiser, United Healthcare, HealthNet, to provide these A and B benefits. But you have to have a primary care doctor who you have to go through to see specialists, and you have to stay within their contracted network of doctors. Okay? You can't just go to a specialist somewhere else in the country. You need to get approval from your plan. Okay? So those are the 2 different ways you can receive your Medicare. For people with end-stage renal disease, the second option is off the table. They exclude people who have end-stage renal disease. But there are plans that are called special needs plans now, and I just learned about one the other day in 2014, being offered in 2014. There's a special needs plan for people with end-stage renal disease through satellite. And if you want to know more about it, I can talk to you afterwards. Question?
I'm under 65. I qualify for Medicare because of my dialysis, and I have Kaiser Senior Advantage. They took me.
Right, so there are some special circumstances. If you had employer group coverage and your insurance offers a Medicare Advantage plan, you can move into Kaiser. You could move into Kaiser or United Healthcare even though you have end stage renal disease. Okay, so some basic, how to cover out-of-pocket costs. So, currently, if you have employer group coverage, that's one way, and it still coordinates with Medicare. Major risk medical insurance can help pay for the 20% that is your responsibility still. We were wondering if this Mr. MIP was going to go away, but it still exists. Medi-Cal still coordinates. And there are these insurance policies called Medigap plans. So Medigap plans are designed to cover the out-of-pocket costs of Medicare. But these were left unchanged by healthcare reform. So companies are still not required to sell this type of insurance to people under 65 with end-stage renal disease. So this is, I don't know why, but this is very unfortunate. I think there are a number of people who need the help to pay for the immunosuppressive drugs. They basically have to pay 20% of the drugs, and there's nothing else to help supplement them. Now, again, I just learned though, and I don't want to give anybody's hopes up, but companies aren't required, but I've heard from a particular broker that he's familiar with a company that does sell to people with end-stage renal disease under 65. So this looks promising. If anyone's interested, I'd like to talk to you and find out, but there are certain conditions that have to be met. Companies can still ask about pre-existing conditions in this health insurance marketplace, though. So when it comes to buying one of these Medigap policies, there's an open enrollment period. So when you first get Medicare, you have 6 months to buy a policy without any health screening. Also, if a person loses health coverage, then you get this guaranteed issue right period to buy a Medigap policy to supplement your Medicare. And the short of it all is, if you're healthy, these Medigap policies that supplement Medicare will be sold to you, if you're healthy. So, suppose you're eligible. Am I eligible for Medicare? I am eligible for Medicare. Are covered California plans an option for me? Basically, no. A person who's eligible for Medicare cannot receive, first of all, any premium tax credits or cost-sharing subsidies. So, when it comes to how much insurance will cost on the exchange versus Medicare, because if you have Medicare, you cannot take advantage of premium tax subsidies or cost-sharing. So, financially, Medicare is still probably a better option cost-wise. Furthermore, if you have Medicare, it's illegal for anyone to sell you a plan on the health insurance exchange. There is an exception for people who have to pay for Part A of Medicare. But this is a very delicate decision. There are penalties that could accrue if you don't pick up Part A or B than you could have. Ben?
Very quick question. You mentioned earlier that for the Medigap policy, there's an open enrollment period of 6 months for Medigap where you're not subject to a healthcare screening, right? So the question is, if you qualify for Medicare due to ESRD at any given point in time, since you qualify for Medicare at that point, is that gap, is that period of 6 months, is that an opportunity for you to get a Medicare plan and not be concerned about the pre-existing condition?
Yes, yes. The question is he just clarifying about the 6-month opportunity to purchase a Medigap policy when you start when you're with your effective date of Part B. Yes, so after that period of time, you have 6 months in which a company has to sell you a Medigap policy. They cannot ask you about any pre-existing condition. Outside of that 6 months, then they could ask you about any pre-existing conditions, and people with ESRD under 65 have not been able to find a policy. If you're over 60, so if you're younger than 65 and then you become 65 and qualify for Medicare, this starts again, and you can purchase a Medigap policy even though you have ESRD.
Is Medicare policy synonymous with Medicare supplement?
Right, the question is, are Medigap policies synonymous with Medicare supplements? Okay. Yes, so a Medigap policy is the only Medicare supplement insurance. The word supplement can be used to say, I want to supplement Medicare with my employer group health plan. Sometimes it's used that way, but technically, Medigaps are Medicare supplement insurance. Okay, so a few things about the Affordable Care Act and how it affects Medicare from the beneficiary's point of view. The largest one that you've probably heard about is the shrinking of the donut hole. The coverage gap is shrinking through 2020. What this means is that a member is no longer responsible for 100% of the drug costs when he or she hits the donut hole. Instead, there are discounts on brand name drugs and on generic drugs. And these are taken at the pharmacy. There's also, just so you know, and this has been around, but there's extra help for people with lower income and resources for drug coverage. So, just in summary, we talked about some of that. There's no more pre-existing condition, elimination of annual lifetime caps, the new health insurance exchange that's opened up. Medicaid has expanded to include a wider population. And there are efforts to improve quality in the Medicare program. One of them is targeting unnecessary hospital readmissions. So hospitals are looking more closely at this because Medicare could penalize hospitals if someone is unnecessarily readmitted. Preventive services too are.
Does that mean?
Yes.
That means they kick you out sooner than you really well enough, and you have to come back in within 30 days. Then the hospital could be penalized.
Right. So saying if you're kicked out of the hospital earlier and come back again, so they're looking at unnecessary readmission. So if first of all you were admitted as an inpatient, not sitting in the emergency room under observation, but if you were actually admitted as an inpatient, discharged, and I think if you return within 60 days, then they're looking at possible penalties for the hospitals. Yes?
That first point seems a little bit ambiguous, because if one is buying expensive drugs, nonsensical, from blast right to that donor hole and pays the same amount as before, it's only if one is on a few cheap drugs that the donor hole appears to shrink.
So the point here is if you're on expensive drugs, you could blow right by the donut hole, meaning you pay out of pocket for a lot of your medications, you enter the donut hole, and quickly you're out of it after you've paid.
$4,000.
Right. So for people on expensive drugs, yes. I mean, some people go through the donut hole before half of the year even hits. Right? So
Sensipar is an expensive drug.
Right.
Often occurs with kidney patients.
right. So basically, this is saying that since the donut hole is shrinking, you're paying a little bit less than you would have paid. You're not paying as much in the donut hole as you would have paid in 2006. So in 2006, you would have had to pay 100% of the cost of your drug when you went through the donut hole. Instead now, you have a discount on that drug. But it depends on some of the drugs, I have to say too. And it's through a manufacturing discount. But the idea is that instead of 100%, you get a discount on your drugs through the donut hole. After the donut hole, you're paying 5% of the drug, or a couple of dollars depending which is more, whichever's more.
I'm still confused about the Obamacare plan. You gonna help?
You're confused about the Obamacare plan. Do you have Medicare?
Yeah, I have.
Okay, so if you have Medicare, you don't have to do anything with respect to the Obamacare plans. I think when we talk about Obamacare plans, we're talking about plans offered through the exchanges. People who have Medicare cannot buy on the exchange and don't need to. The other thing with the Affordable Care Act is the Medicare and Medicaid Coordination Office. People who have Medicare and Medicaid often found coordination of their care between these two systems quite difficult, and so there are pilot projects now that are testing new deliveries of care for people with both Medicare and Medi-Cal. One of them is called CalMediConnect. So Santa Clara County is a demonstration county, and we've been looking at enrolling. Enrolling people will be starting no sooner than January 2015. The other thing about the Affordable Care Act is an increase in preventing fraud and abuse. So I just want to mention a few things for people with Medicare is guard your Medicare card, don't give it out. If someone calls and says, you need a new Medicare card, what's your Social Security number? Don't. Simply because Social Security and Medicare, they already know what your information is. And also ask yourself, did I receive this particular service? In that way, you can track and help with the vast amount of fraud that's actually in the system.
They ask for security questions.
Who does?
Medicare, as well as.
Yeah, so if you call Medicare, it's one thing. But if someone calls and says, we're from Medicare, what's your Medicare number? They know you're. So if you sense anything, definitely give us a call. Yeah.
Yeah, I was just going to mention that, I was considering going to the covered California because the premiums were going to be less. But when I really spent the time and called all the different hospitals and doctors, even though they showed up as being covered under the covered California, when you call them, a lot of them have not finished their contracts. So if you go on the plan now and you go, let's say, to Sequoia Hospital, they can't, you're actually not covered. It's not a participating institution because they haven't finished the contracts between them. So you have to be really cautious. And some of the, groups where different hospitals that have transplants and so on aren't even participating with those insurance companies.
Right.
So it's a really tricky kind of thing because, it seems like if you've got Anthem Blue Cross, and then you say, oh, I've got Anthem Blue Cross under the color of California, it's not the same at all as far as what the contracts are.
Right. So she looked at these plans a little closer, and when it comes to coverage in many of these plans, you have to ask who is in your provider network, who's contracted with you. Otherwise, I think that's probably the most important thing when it comes to figuring out which plan to pick. That's definitely one of them. Who's in your provider network, and is my doctor, my facility part of that network? If not, then there's no point.
But you can't just trust what they have on the covered California, so you have to call each one.
Right.
Because they're in different stages of finalizing their contracts.
Yeah. So go directly to the source after you've done some research if this is what you're doing. Is there another question?
Yeah, two things. Is California Care and Medi-Cal connected? They're the same thing now, or are they separate?
They're separate, but because they're both screening people based on modified, when it comes to whether you are eligible for Medi-Cal or if you qualify for subsidies and help through covered California plans, they're both looking at the modified adjusted gross income now. So they're separate programs, but they work together to try to get you to what's most applicable for your situation.
The other thing is, does California Care, like Medi-Cal, take their money back when you die and you have assets?
No. California, these are health insurance plans that you still have to pay, but they're the tax subsidies, not that I know of, I don't think you have to pay those back.
Thank you.
Okay. Questions, yes?
Can you talk about the small business health options program?
Right, so something we didn't talk about, there are a lot of small businesses that, because of the price of insurance, would not offer their employees health coverage. So in addition to Cover California, for the individuals, there's what's called the Small Business Health Options Program. It's called the SHOP, where small businesses can go to look for more affordable insurance for their employees. Employers with 25 employees or less can receive some subsidies and help offering such insurance to their employees. California started theirs just last month, so I think if there's less than, I think a couple thousand already enrolled, but we just started. It's been delayed in other parts of the country.
Is that under Covered California or something else then?
It's called SHOP, but you can get to it through the Covered California website, so it's coveredca.com. Yes?
I keep reading that the Medicare Advantage programs are changing under ACA, but you didn't mention it.
Right, so Medicare Advantage plans changing under the ACA. So maybe you've heard that billions of dollars have been removed from the Medicare program. Has anyone heard that? Okay. So what does that mean? If, let me just go back to this slide. The two ways of receiving Medicare. The original Medicare or Medicare Advantage plans. Okay, so Medicare Advantage plans are private plans. Original Medicare works like this. So a beneficiary goes to a doctor, the doctor bills Medicare, Medicare pays the doctor 80%, the patient's responsibility is 20%. Some studies have shown in the past that, in the way Medicare Advantage plans work, instead of paying per service, Medicare pays a health plan a certain amount of money each month for their enrollee. It's called a capitation. So for example, maybe Medicare will pay $800 to the plan, and the plan uses that $800 each month, regardless of whether the person needs it or not, to take care of your A and B benefits. Okay. So a study was done to see, well, how much does Medicare pay per beneficiary under original Medicare, and what's the quality of their care, versus how much we spend on capitation to Medicare Advantage plans. And what they found was Medicare was paying 13% more per beneficiary to Medicare Advantage plans for no greater benefit. And so the idea behind this reduction, basically saying Medicare is going to take the capitation that's been given and bring it more in line with what we're spending on original Medicare beneficiaries. So over 10 years, that figure, the billions of dollars being taken out of the Medicare program, a lot of it comes from that readjustment of payment. So looking at Medicare Advantage plans, we haven't seen any, these plans, they can change, they can come into the market. Maybe you've heard of HealthNet dropped a plan. A lot of people had to look for a Medicare Advantage plan. These rules have been in existence. They raise their premiums, raise their co-payments. They can do that each year, regardless of the ACA. But that's where kind of the biggest change for Medicare Advantage plans is. It's for, it really doesn't, the beneficiary doesn't see much of that change. Any other questions? Okay. Thank you very much.